Wait on that.
4 minutes, sir. That also I lost. Sir, headphone மாதிரி ஏதாவது இருந்துச்சுன்னா நல்லா இருக்கும்.
அதான் பார்க்குறேன். பரவாயில்ல கேட்டு.
ஹெட்ஃபோன் இருந்தா கொஞ்சம் இதா இருக்கும்.
அதான் பார்க்குறேன். பட்
ஒரே ஒரு நிமிஷம் சார்.
ஒரே நிமிஷம். இதையும் கொஞ்சம் பெருசு பண்ணும். லேப்டாப் ஒன்று காணும். வருது இல்லையே. F4 அது F3
F4 தான் சார். 1 minute சார். 1 hour. சார் அந்த இடத்துல கூப்பிடுங்க.
F5 வரும்.
நீங்க அட்ஜஸ்ட் பண்ணீங்க.
கண்ட்ரோல் F5 வந்துரும்.
ஒரே நிமிஷம் ஹெட்ஃபோன் மட்டும் நான் வாங்கிக்கிறேன்.
இதுல நம்ம ஹாஸ்பிட்டல் அஃபிலியேஷன் போட மாட்டாங்களா? பரவாயில்லையே.
போட சொல்லுவா சார். இல்ல அவங்க கண்ட்ரோல் அந்த ஸ்வேதாங்கிறவங்க பாம்பேல இருந்து கண்ட்ரோல் பண்றாங்க.
ஓ சரி சரி.
சார் क्वेश्चंस மட்டும்
அது கடைசில வருமா பிரசன்டேஷன்? சோ அத நாம வந்து ஆன்சர் பண்ணனும் அப்படிங்கறாங்க. நீங்க அப்படியே பாருங்க. நீங்க சேர் எடுத்து.
ஹலோ.
If I can type நான் டைப் பண்ணிடுறேன்.
Sweta, actually this doctor the hospital application is not patient care.
Can I do? இருக்கு நெக்ஸ்ட் பேஜ்ல இருக்கு. இருக்கு நெக்ஸ்ட் இதுல இருக்கு. நெக்ஸ்ட் இதுல இருக்கு.
Next it is there. It is there. Hello. It is there.
பரவாயில்ல இருக்கட்டும் அதுல இருக்கு.
It is here and otherwise I provide example application. Okay. Sir, just he was telling that headphone are not required. It's already done. That's why you are arguing this. Okay.
என்னதான் சொல்றாங்க மக்கள் பார்க்கலாம்.
சார் ஏற்கனவே பண்ணிருக்கீங்களா?
இந்த மாதிரி இல்ல. I've done from my room something like this. Questions will pop up. I'll just type the answer.
No live.
No live.
இன்னொரு சென்டர் இருக்கு சார் ஆக்சுவலா. பூகன் டவர்ஸ் அந்த விசாலாம் கொடுப்பாங்க.
ஆமா.
எக்மோர்ல பூகன் டவர்ஸ்னு சொல்லிட்டு விசா அந்த பாரிஸ் யூஎஸ் விசா எல்லாம் அங்கதான் சார் இருக்கு. அந்த அங்க இதோட இன்னும் பயங்கர அட்வான்ஸ்டா இருக்கு பிளேஸ் கிடைக்கும். எல்லா ஃபார்மா கம்பெனிஸ் அங்க வச்சுதான்
போட்டுடுவோம். எப்பயும் ஒரு 80 ஸ்லைட் இருக்கு, நம்ம பேசுறதுக்கே 1 hour ஆயிடும்.
சார் என்ஜிடி சாப்பிடுறேன் சார் ஜூஸ் எல்லாம்
முடிச்சதுக்கு அப்புறம் வந்த வேலையை முடிக்கும். நீங்க சாப்பிடுங்க. both of you have coffee.
சார் டீ மட்டும் குடிங்க.
இல்ல இல்ல எனக்கு வேண்டாம். எஸ்டர்டே சார் அப்புறமா அதாவது சார் 323 தான்.
கரெக்டா 5 o'clock 3 to 5 நாங்க பேமெண்ட் பாம்பேல இருந்து இருக்கோம்.
நம்ம 3:30 to 4:30 முடிஞ்சிரும்
சார். ஆக்சுவலா அப்புறம் क्वेश्चंस அவங்க போஸ்ட் பண்ணுவாங்க.
இல்ல நம்ம டோட்டலாவே 3:30 to 4:30 குள்ளயா இல்ல 5 வரை இருக்கு?
இல்ல 5 வரை இருக்கு சார். அவங்க 3:20க்குலாம் வந்து நீங்க ஸ்லைட்ஸ் முடிச்சிட்டீங்கன்னா क्वेश्चंस போஸ்ட் பண்ணுவாங்க.
4:20
4:20 4:25 क्वेश्चंस வந்து போஸ்ட் பண்ணும்போது அவங்க நீங்க எதுக்கு அவங்க நீங்க ஆன்சர்ஸ் நீங்க டைப் பண்ற மாதிரி இருக்காது.
ஹலோ 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 சொல்லுங்க. இல்ல நம்ம என்ன பண்ணலாம் 100 OD அமியோட்ரான் வச்சிடலாம். இல்ல அமியோட்ரான் கூட வேணாம். AF கம்ப்ளீட் ஹார்ட் பிளாக்ல இருக்காங்கல்ல, she will need oral anticoagulation 0.5 and 1 mg acetrom on alternate day. அப்புறம் பீட்டா பிளாக்கர் ஒண்ணு அதை போட்டுடலாம். அவங்களுக்கு ஹைப்பர் டென்ஷன் பிரஷர்லாம் எப்படி இருக்கு? ஆம்லோடிபின் எவ்வளவு போயிட்டு இருக்கு? அதை ரெடியூஸ் பண்ணி 2.5 OD வச்சிடலாம். ஆசிட்ராம் பீட்டா பிளாக்கர் வேணுங்கிறது இல்லை. அப்போ ரேட் கண்ட்ரோல் AF கம்ப்ளீட் ஹார்ட் பிளாக் தானே, ரேட் கண்ட்ரோல் தான் இருக்கு. ஸோ அமியோட்ரானும் வேண்டாம், பீட்டா பிளாக்கரும் வேண்டாம். ஆம்லோடிபின் 2.5 OD and acetrom 0.5 and 1 mg on alternate days 001. ஏதாவது வைட்டமின் ஒண்ணு ஒரு வைட்டமின் போட்டுருங்க. That's all. அப்புறம் டயக்னோஸ்ல AF கம்ப்ளீட் ஹார்ட் பிளாக். நான் இந்த வெபினாருக்கு வந்திருக்கேன் ஒரு 1 hour 4:30 வரை. I may not pick up the phone. After 4:30 again I will come. Sure.
Okay, only camera we have to adjust or you will adjust? Okay. And doctor is ready actually. Anytime you can stop. That is yes. Sami, what time? Yes. Sami, what time questions? Okay, questions. Okay. Okay, I'll inform. Sir, once the presentation is over, sir, automatically second page will open, sir. That page
will have questions. I saw this actually in the Pododa. Maybe I can show you. So, a response. ask a question, name, doctor name, location எல்லாம் போட்டு அது மாதிரி வந்துடும். இது நம்ம பேஜ் இதுல கண்ட்ரோல் F5 போட்டு அதை பண்ணிடும்.
எல்லாம் கேமரா இது ஆடியோ குவாலிட்டி எல்லாம் இருக்கேன் சார். கேமரா மட்டும் அங்க அட்ஜஸ்ட் பண்ணிட்டேன். 2 மினிட்ஸ்
பண்ணும்.
ஒன்றும் கொடுக்குது அந்த ஆமாம் சார். இன்வெஸ்ட் பண்ணி வச்சிருக்கேன் சார். இன்ஃப்ராஸ்ட்ரக்சர் 100 rooms in house.
For this purpose அந்த மாதிரி
இல்ல சார், நிறைய வேரியஸ் பர்பஸ். ஆனா பட் எங்க ஃபார்மா கம்பெனிஸ் அந்த ஃபுட் அண்ட் டவர்ஸ் அப்படி இல்லைன்னா இங்கிலீஷ்.
அதான் முருகன் was telling that we'll do in this place sir because it is closer to MMM. I said okay, I have no problem.
Camera is ready. Okay. Start. Okay.
Paper எல்லாம் வச்சுக்கலாம் just in case I want to write something.
You start பண்ணிடுங்க சார்.
Whenever they tell, I'll start.
Okay. 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 Laptop. Okay. Now okay. Towards doctor. Towards doctor. Okay. 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 Now it's okay. Okay. Sir, please stop.
We can start. Good afternoon, dear friends. I am Dr. Jaishankar, Senior Cardiologist from the Madras Medical Mission in Chennai. I am here to talk with you all regarding the latest in hypertension management. The topic allotted to me is paradigm shift in hypertension management. At the outset, I am thankful to Lupin Pharma for arranging this webinar. And without wasting much time, we'll go on to the burden of hypertension in our country. Hypertension is the most common non-communicable disease. And it is estimated that 10% of all deaths are attributable to hypertension. The prevalence has increased dramatically in the past 3 decades, from 5% 30 years ago to 20 to 40% in urban areas and 12 to 17% in rural areas. So what does this translate into? Every third urban Indian is hypertensive, And every fifth villager in India suffers from hypertension. So if we put it together, we have something like 35 crore hypertensives in this country out of a population of 125 crores. We see that top 10 causes of death in India, leading cause of death remains ischemic heart disease. And we all know that hypertension is one of the very important causes for ischemic heart disease as well. And on its own, de novo, hypertension happens to be the 9th leading cause of mortality in our country. Some important facts, we behave a little differently compared to our Western counterparts. The prevalence of hypertension, as I said earlier on, it is 1 in 3 urban Indians and 1 in 5 or 1 in 4 for the rural Indian. But importantly, the awareness is pretty low. Only 42% of urban Indians are aware that they are hypertensive, and only 25% of rural Indians are aware that something called high blood pressure. This very important data which got published in Journal of Hypertension from our own country. Importantly, even in the Western world, not all hypertensives are under good control, despite good medications which are available today. And in our country, it's still more dismal. 1/10 of rural and 1/5 of Indian urban hypertensives have the blood pressure under control, so which is not a good sign. There's a huge burden attached to this high blood pressure. It is directly or indirectly related to 57% of all stroke-related deaths, 25% of coronary heart disease deaths, 14-20% of chronic kidney disease, 21% of peripheral vascular disease, and cataracts as well. So the complications which can be ascribed to hypertension are coronary heart disease, stroke, hypertensive heart disease causing heart failure, and peripheral arterial disease. As I said earlier on, hypertension is responsible for 57% of all stroke-related deaths and 25% of coronary heart disease deaths in our country. The burden being huge, it doesn't occur in isolation. Hypertension runs concomitantly with other risk factors, both in men and women. And if you see the comorbids, obesity, reduced HDL cholesterol, impaired glucose tolerance, hyperinsulinemia, high LDL, and triglyceride and left ventricular hypertrophy are some of the known common associations of hypertension causing problems to our countrymen. And more than 50%, every second hypertensive has more than 2 comorbid conditions affecting him. So either they have 2 comorbid conditions or 3 or more than 3 or 4, similarly in men and women. We know the cause for inadequate control of blood pressure is several. Physician inertia is a very important factor. So we should strive hard to get the blood pressure control no matter what we do in our patients for the betterment. We should use judicious combination of drugs because ineffective drugs will lead to inadequate control of blood pressure. There will be a small fraction of patients who are resistant. Of course, there is every guideline coming out every other year and we are forever confused what guideline to follow and what should be the target. Drug costs can be huge, enormous, so we need to choose the drugs appropriate to our countrymen, which are not too expensive. We should also have compatible drugs so that when we use multiple drugs together, there should not be any side effects. And we should ensure compliance during every visit the patient makes to us. If we see the goal of hypertension, different groups are there, like JNC8, European Society of Hypertension, the American Society of Hypertension, or American Heart Association. So hypertension is defined when the blood pressure is consistently elevated above 140/90. 140 systolic and 90 mm or more diastolic. And there's always an issue of compliance and persistence with treatment. We know that those who are started on appropriate drugs, as we all do, only half of them, end of 1 year, remain compliant to therapy. That's a very important factor to bear in mind. 50% or more would stop their drugs in the next 2 years. So hence, choice of drugs is going to be very important. Comorbid conditions have to be taken into account. How soon we get the blood pressure under control, when to start treatment, these are issues which forever will be bogging us. The implications of hypertension until the year 2000 was acute events in the form of ischemic heart disease, stroke, and premature death due to cardiovascular causes. But what we have realized in the last few years is hypertension is also a chronic disease, can lead to chronic heart failure with preserved ejection fraction, the so-called heart failure, diastolic heart failure. It can also be attributable to systolic heart failure. Hypertension due to elevation in left atrial pressures, the filling pressures, is now known to cause atrial fibrillation, which is again a bad disease to control, chronic kidney disease, and of course, dementia. What we have seen from epidemiological studies is whenever the blood pressure increases 20/10, the cardiovascular mortality increases significantly. The cardiovascular mortality doubles whenever with each 20/10 mm mercury blood pressure increase. Meta-analysis of 61 studies involving more than 1 million patients between 40 to 70 years of age has shown that whenever the systolic blood pressure increases from 115 to 135 to 155 to 175, we see that there's a doubling of cardiovascular risk from 2-fold to 4-fold to 8-fold. And if you extrapolate the same, whenever there is a reduction in blood pressure, no matter how we achieve it, it leads to a reduction in mortality. A mere 2 millimeter systolic blood pressure reduction leads to 6% reduction in stroke, 4% reduction in coronary heart disease. When we reduce the systolic blood pressure by 3, the stroke incidence is down by 8, CHD down by 5. And if you are able to achieve a stroke blood pressure reduction systolic greater than 5, we're looking at something, a huge benefit, more than twice compared to 2 millimeter fall in blood pressure in the form of stroke reduction 14% and 10% coronary heart disease reduction. So this meta-analysis, which was published a good 15 years ago in the Lancet, is a very important landmark analysis where a 10 millimeter decrease in systolic blood pressure has shown to reduce mortality due to ischemic heart disease by 30% and mortality due to stroke by 40%. So it's important that we identify these patients with risk factors. As I said earlier on, more than half of the patients have greater than 2 comorbid conditions. It is important to identify these risk factors in management. Whenever the patient has a symptomatic cardiovascular disease, has chronic kidney disease, stage 4 or more, or diabetes, or various factors, he is at a very high risk of events, no matter what the blood pressure level may be, starting 130 systolic and 90 diastolic. And the greater the increment, the greater the risk to these patients. Vis-a-vis somebody who has a blood pressure 140/90 and no risk factor. So that's how the comorbids, they play hand in hand. So a very important landmark trial has got published very recently in the New England Journal called the SPRINT trial, which is systolic blood pressure intervention trial, because now we know that the reduction of systolic blood pressure is paramount as far as reduction in cardiovascular mortality is concerned. It was a randomized open label trial conducted over 100 centers, more than 9,000 patients involved. 2 types of treatment arm was taken. One, the standard treatment group where all of us have been trying to reduce the blood pressure to systolic less than 140 and diastolic less than 90, or the intensive treatment arm where the blood pressure was reduced further below 120 millimeter. So all these years, we were given to understand that if you go down in systolic blood pressure, there's a J curve and there's a higher mortality when the systolic blood pressure is reduced too low. And what did the investigators look out for? They were looking for a composite outcome of myocardial infarction, acute coronary syndrome, stroke, acute heart failure, or death from cardiovascular causes. This trial had to be stopped at the end of 3.2 years. The average trial design was to follow up for 6 years, owing to a significant decrease in primary composite endpoint in those who were in the intensive treatment arm compared to the standard treatment arm. Meaning, those whose systolic was reduced to less than 120 did far better than those in whom conventionally we've been trying to reduce the systolic to less than 140. There was a 27% lower relative risk of death from any cause, 25% lower risk in primary outcomes as enumerated earlier on, 38% lower risk of heart failure, and 43% lower risk for death from cardiovascular causes. The all-cause mortality, if you see death from cardiovascular causes in the intensive treatment arm as shown in the dark blue bar here, compared to the standard treatment arm, was significantly lower, and so was the all-cause mortality as well. The trial, as I said earlier on, was stopped early due to benefit after median follow-up of just 3 years, lesser heart failure, lesser death from cardiovascular causes. And this is basically a ARB trial, angiotensin receptor blocker, azilsartan, the newer one, or its combination with losartan, with chlorthalidone and losartan. And azilsartan was used at a loading dose of 40 to 80 milligram once a day. Nearly 40% of the patients were in the intensive treatment arm, and 27% were in the standard treatment arm in those who received either azilsartan or losartan. The SPRINT trial investigators report that treating very high-risk hypertensives who have 3 or more comorbid conditions older than 50 years to a target of 120 millimeter or low had a significantly reduced cardiovascular events and reduced all-cause mortality, which is 25% when compared to conventional treatment of targeting the blood pressure, the systolic blood pressure, to 140 millimeter or less. So this was the first study, contrary to what I said earlier, contrary to popular belief that intensively lowering the blood pressure could prevent cardiovascular complications and save lives. Meta-analysis of BP lowering studies beyond SPRINT. There are about 123 studies which include SPRINT over 6 lakh patients. For every 10 millimeter reduction in systolic blood pressure, there's a significantly reduced major adverse cardiac event. BP lowering significantly reduces vascular risk whenever the blood pressure is more than 160 through 130 and comorbidities included. But nothing can substitute our clinical judgment. We have to see the clinical circumstances, patient preferences. Are they very symptomatic with the intensive treatment? We have to use experience and judgment with caution, and of course back it up with solid scientific evidence. We know that the hypertension is perhaps the gateway to cardiovascular continuum. There's a huge gap between prevalence, detection, and control of hypertension. Uncontrolled hypertension poses economic burden, causes morbidity and mortality. Benefits of blood pressure reduction is huge as far as cardiovascular events concerned. And of course, SPRINT trial, which was published a year ago in the Lancet, shows very clearly that greater mortality reduction with the intensive blood pressure treatment. If you see the legacy, how antihypertensive drugs were developed more than half a century ago, starting with reserpine from the raw Wolffia alkaloids from the tree bark, to thiazides, to calcium channel blockers, to diuretics, to beta blockers, to alpha blockers, to ACE inhibitors, we have come a long way. And basic concept of treatment of hypertension revolves around reducing the peripheral arterial resistance or reducing the cardiac output. We know that blood pressure is an end product of cardiac output and peripheral vascular resistance, the total peripheral resistance. And this cardiac output in turn is determined by heart rate and stroke volume. So we try to reduce the heart rate by beta blockers. We try to reduce the peripheral resistance with vasodilators in the form of calcium channel blocker and angiotensin receptor blocker and ACE inhibitors. These drugs, the four major class of drugs, are different, but many of them have complementary mechanism of action, which is very important as far as selection of combination therapy is concerned. If you look at these four class of drugs, the A, B, C, D drugs, as they are called, ACE inhibitor or ARB, beta blocker, calcium channel blocker, and diuretics, they have problems of their own. We know that ACE inhibitors have quite a lot of cough as a limiting side effect. Beta blockers are not very comfortable as far as diabetics are concerned. They cause impairment of glucose and lipid metabolism. Calcium channel blocker, if you increase the dose of amlodipine from 5 to 10, almost always most patients will report ankle edema. And diuretics may not be very well tolerated, particularly when the patients are diabetics and they can have precipitation of gout. Angiotensin 2, which is generated via AT1 receptors, is directly responsible for a lot of problems as far as cardiovascular tree is concerned. This angiotensin 2 is the most powerful vasoconstrictor known to mankind. It causes vascular hypertrophy, leads to endothelial dysfunction, promotes atherosclerosis, that can in turn lead to hypertension, and it is also a prothrombotic state. Angiotensin 2 causes apoptosis, left ventricular hypertrophy and fibrosis. This predisposes the patients to arrhythmias, heart failure, and myocardial infarction, can cause stroke and cognitive decline, can decrease the GFR and leading on to proteinuria and albuminuria, and also renal failure. So then the problem comes, how do I target this angiotensin 2? If I use an ACE inhibitor, it can prevent the generation of angiotensin 2 because it acts in between AT1 and AT2. And ARB can target the type 1 receptor of angiotensin 2. So if we see the efficacy of controlling high blood pressure, both are favorably predisposed. Both ARB and ACE inhibitor are able to control the blood pressure. If you see the efficacy for reducing cardiovascular and renal outcomes in high-risk patients, heart failure with systolic dysfunction both have been shown to have equal efficacy. Chronic kidney disease both are equal. Diabetics with end organ damage have equal efficacy. For recurrent strokes, we do not have enough data. Without heart failure, ARB is probably as good as ACE. But as far as tolerance and adherence is concerned, and ARB has shown in almost most of the trials to have better tolerability and greater adherence on a long-term basis. The cost, however, is marginally higher. So cost may be the option as far as AC is concerned, and adherence may be the option as far as ARB is concerned. In those high-risk patients without heart failure, the data with angiotensin receptor blocker is not very robust, but we do have data on some ARBs in heart failure. So they do have some favorable effect as far as genesis of diabetes is concerned. They have a favorable effect on the pancreas as far as adipocyte differentiation is concerned. They preserve the pancreatic insulin secretory response, prevent inappropriate gluconeogenesis in the liver, cause vasodilatation, prevent hypokalemia, and improve the peripheral insulin sensitivity. The ARBs, different types, have shown to have a pleiotropic effect, like we speak about pleiotropism in for statins. They are known to reduce the oxidative stress, decrease platelet aggregability, reduce inflammation in the vessel, decrease vascular smooth muscle cell proliferation, improves the arterial compliance, improves the plaque stability, improves endothelial function, decreases collagen matrix formation by reducing the matrix metalloproteinase, the MMP, decreases mononuclear cell migration, and decreases fibrinolysis. A lot of ARBs have been studied over the last 30 years, starting from ELITE 2 to VALHAF to Optimal to LIFE to IDNT renal roadmap. And they have consistently been shown to be quite effective as far as morbidity and mortality endpoint trials are concerned, whether it is irbesartan, candesartan, losartan, valsartan, or telmisartan. The renin-angiotensin system is involved in various processes like endothelial dysfunction, vascular inflammation, arterial stiffness, atherosclerosis. And two important trials like the VAMOS and CONFIRM have shown that the mechanism of target organ damage along the cardiorenal continuum in patients with hypertension and metabolic syndrome have been favorably altered by ARBs. And high dose of ARB could retard and regress organ damage, particularly arterial stiffness, which is a forerunner of atherosclerosis and vascular tree inflammation. So if you go back and see what do the guidelines say, the very recent release about a couple of years from the International Society of Hypertension and American Society of Hypertension has shown that whenever adults more than 18 years have consistently 3 or more readings higher than 140 by 90, and for the very elderly, whenever the age, when more than 80 years, the pressure is greater than 140 by 90, we have to start lifestyle modification in the form of weight reduction to ideal body weight for that height, decrease in dietary salt intake and alcohol consumption, and cessation of smoking being paramount as far as every patient is concerned. We could delay start of treatment in uncomplicated stage 1 hypertension, the ones who have a blood pressure 160 by 100 or less, compared to stage 2 hypertension, whenever the blood pressure is greater than 160 by 100 on different occasions, drug therapy has to be started. But for those between 160 to 100, 160 by 100, lifestyle modification can be given a good try. If it doesn't work, for black patients, we are aware now that ACE and ARBs do not act well. So we need to consider a calcium channel blocker or a thiazide. Non-black patients like our Indian ethnicity, age less than 60 years, we should prefer ACE or ARB, and more than 60 years, we should prefer a calcium channel blocker. If the BP doesn't get controlled, we should add a thiazide diuretic or combine ACE with calcium channel blocker or ACE with or a diuretic. Or we can use an ACE ARB or a thiazide plus thiazide and a calcium channel blocker. However, if a patient has a blood pressure greater than 160 by 100, all the time we are supposed to start two drug regime because the failure of monotherapy is going to be very high, and these are very high risk patients. And if the BP doesn't get controlled, we can add a MRA, a mineralocorticoid receptor antagonist like spironolactone, or centrally acting agents or beta blockers. And most of these guidelines for all group, first line of option has been to use a ACE or ARB, and we see ARB will score over ACE as far as the compliance and tolerability is concerned. So amongst the various ARBs which are available to us for use, losartan was perhaps the first and most widely studied ARB. It also has an additive uric acid lowering property. It has a shorter half-life and needs to be administered twice a day. Valsartan was the first FDA-approved ARB for heart failure after MI. It also has a short half-life and required to be administered twice a day. Telmisartan has very positive effect on lipid and glucose metabolism. It's a long half-life for 24 hours, but unfortunately is a mild antihypertensive. And olmesartan is more compared to any of the previously known sartans as far as double-digit blood pressure control is concerned. So we have to start thinking of, and olmesartan in some studies has shown to be having a higher risk of induction of diabetes with time. So multifunctional ARB, where the blood pressure could be controlled more powerfully. If the drug is more effective than existing ARB, consistent blood pressure lowering or optimal treatment choice is perhaps the need of the hour. That's the reason a new ARB had to be looked upon. So amongst the evolution of ARBs, losartan, as I said earlier on, was the first to study, followed by valsartan, candesartan, telmisartan, olmi, and now lately azilsartan about 5 years ago. So despite olmesartan having a double-digit blood pressure control, what is the need to look at a newer drug? We'll come to that subsequently. The new sartan on the block happens to be azilsartan. It has a peculiar molecular structure. It has a modified tetrazole ring, as shown here in the ring, which makes it less acidic and more lipophilic. And because of its high lipophilicity, the bioavailability is more. Its affinity for the AT1 angiotensin 2 type 1 receptor is very high and very selective, and this leads to very slow dissociation of the molecule from the AT1 receptors. And if you see the time course of dissociation, it has got a very slow dissociation as shown here compared to all other ARBs, including olmesartan, telmisartan, and valsartan. And the binding affinities are also very different. If you see the 50% inhibitory concentration, there it is, azilsartan on top. It is a novel ARB. It increases because of its very selective angiotensin 1 receptor blockade, leads to elevation of angiotensin 2, angiotensin converting enzyme 2, thereby angiotensin 1 to 7 levels, which is protective because angiotensin 2 causes vasoconstriction, leads to reabsorption of salt and water, inflammatory, and it is vasculotoxic. And straight opposite is the angiotensin 1 to 7, which acts through the MAS receptors in the endothelium, causes vasodilatation due to nitric oxide release, causes diuresis and natriuresis, and also has a vasculoprotective effect. So that's so much so as far as the antagonistic effect of the angiotensin 1 to 7 mediated by the MAS receptors, which is promoted by azilsartan. It reduces 24-hour ambulatory blood pressure in hypertensive humans. It is found to be more potent than other ARBs and better responder rates. It has also shown in clinical studies to be well tolerated, and the rate of withdrawal due to adverse events was similar to placebo. So azilsartan is now being recognized as an important drug as far as blood pressure control is concerned. A lot of primary care physicians have been interviewed in different studies, and major findings are reduction in blood pressure and cardiovascular events, which is very important for all of us, and all of us are looking at drugs which can reduce the blood pressure more effectively, even the resistant hypertension, so that we can reduce the cardiovascular events. So based on this, on its clinical profile and data available by interview from various physicians across the globe, is perhaps it is the clinical gold standard in the drug comparator model. So what is the rationale for the gold standard status? It has efficacy benefits over other concurrent therapies, has shown superiority in blood pressure control over valsartan and ramipril in phase 3 clinical trials involving humans. So what is special about the drug? The diazole ring on azilsartan is not found in any commercially available, clinically approved ARB. So this modification in the molecule has made it less acidic and more lipophilic and more bioavailable. It has clinically been shown to lower the 24-hour blood pressure in hypertensive patients significantly more than the maximum approved dose of olmesartan and valsartan. It has a greater potency at persistent AT1 receptor blockade because it dissociates from the AT1 receptor pretty much slowly. It takes long period of time, and that's why it is truly once a day dosing. The tight binding and slow release leads to slow drug washout. This dissociation from AT1 receptor is more slow than olmesartan, telmisartan and valsartan. There are effects which are additional beyond the AT1 receptor blockade in BP lowering. The blood pressure drop is to the tune of 15 by 10 millimeter mercury with a 40 milligram tablet, and the bioavailability is something like 60%, and excretion is half renal and half biliary. The recommended dose of the molecule is 40, going on to 80 once a day. It's a prodrug, gets hydrolyzed in the gastrointestinal tract to its active metabolite azilsartan. The bioavailability is about 60%, and food does not interact with its bioavailability. It's very highly plasma protein bound, mostly to serum albumin, and the peak concentration is achieved within 1.5 hours of ingestion of tablet. The elimination half-life is 11 hours, and it is sort of equally excreted by the renal and urinary tract. Renal and GI tract. Lot of clinical evidence pouring in from and getting published in good journals like Hypertension and Journal Clinical Hypertension. Comparison of azilsartan with valsartan or olmesartan, with ramipril, with placebo even in black patients where we know that ARBs are not as effective as calcium channel blocker, versus diuretics and versus amlodipine. So almost all class of drugs have been compared, and patients between 500 to 1300. So when azilsartan is compared with the placebo, olmesartan or valsartan, there's a greater reduction as far as systolic blood pressure is concerned. At 1 week, the compliance level increases further. More response rates. When we say response, we are looking at a 20/10 fall in systolic and diastolic blood pressure respectively. So when azilsartan is compared with ramipril, at 20 milligram starting dose going on to 40, or a 20 milligram starting dose titrating to 80 compared to ramipril 2.5 to 10 milligram, the result is going to be more dramatic. At 20 millimeter systolic blood pressure reduction, quite readily achievable with either of the two drug dosages, 40 and 80 of azilsartan, which is rarely, if ever possible, with a monotherapy with ramipril, as has been studied. And the mean blood pressure reduction persistently is less, both systolic and diastolic, when the patients are on 40 or 80 milligram of azilsartan vis-a-vis ramipril. In stage 1 and 2 hypertension, non-severe hypertension, still azilsartan 40 and 80 seem to do a job much better than ramipril as far as control of blood pressure is concerned. Meta-analysis from randomized controlled trials got published a couple of years ago on azilsartan therapy, 7 randomized controlled trial for BP reduction involving more than 6,000 patients. So whether it is systolic or diastolic blood pressure, clearly azilsartan has been shown to be far more effective than its comparator ARB. We are looking at a systolic blood pressure fall anywhere between 20 to 30 and a diastolic blood pressure fall anywhere between 10 to 12 millimeter mercury in almost all the registry data from multicentric trials in established hypertensives. And this has been proven to reduce the blood pressure, both central and brachial blood pressure. When patients have been on other drugs with no greater fall, we know that a raised central aortic blood pressure is directly related to cardiovascular events in the form of strokes. Those in whom the central aortic blood pressure could not be brought under control with other drugs, when they were substituted with azilsartan, there was a greater response. Rather, this was seen as early as 4 weeks after switching on the therapy, as shown here. Brachial, systolic blood pressure, mean pressure, pulse pressure, and aortic blood pressure. So for stage 1 and 2 hypertension, as I said earlier on, when we compare them with ramipril, when the patients have comorbid conditions, as shown in this trial, randomized for 24 weeks, 800 patients, mean age around 57, 40 or 80 mg of azilsartan compared with ramipril, titrated to 10 milligram. And if we see the blood pressure, clearly both these dose of azilsartan was far superior in achieving blood pressure control. When azilsartan is compared with olmesartan and valsartan, a comparison being by ambulatory and clinic blood pressure in patients with diabetes and pre-diabetes, again, both 40 and 80 milligram of azilsartan was more clearly superior to valsartan and olmesartan, as shown here, the yellow and orange bars being azilsartan 40 and 80 milligram respectively, vis-a-vis olmesartan, and whether it is normoglycemic, pre-diabetic or diabetic, it had a greater magnitude of reduction in systolic blood pressure at the maximally approved dose of olmesartan, which is 40 milligram. And this could have important clinical implications in this very high risk patient group, because diabetics, as we all know, are a very high risk clinical group. And the same thing has been seen when diabetics have been put on valsartan and compared with azilsartan 40 and 80. Clearly, the reduction in systolic and diastolic blood pressure is far superior with azilsartan group compared to valsartan in this high risk patient population. The pharmacokinetics of azilsartan renal impairment is worth a mention, because if you see the area under curve, the area under time concentration curve for those with normal renal function, which is blue, and compared to end-stage renal disease over here, there is varying degrees of renal impairment. For single dose azilsartan, you see that the pharmacokinetics is pretty suitable. That's the reason there's no dose adjustment required as far as renal failure is concerned. Any degree of renal impairment, the area under the curve, as shown in the previous graph, is very favorable as far as the time concentration coefficient dependent curve is concerned for azilsartan compared to other sartans. And importantly, 40 milligram once a day is well tolerated, and there's no real need to adjust the dose with any degree of renal impairment, including end-stage renal disease. Azilsartan also has been studied in hemodialysis patients on hemodialysis, though the numbers are not great. Still, these are the group of patients in whom the blood pressure control is very difficult to achieve. Something like significant systolic fall, more than 20, and demonstrated by measuring the serum noradrenaline levels and LV mass index, which were both favorably altered. So olmesartan, when used in hemodialysis patients with uncontrolled hypertension, is compared with azilsartan. Again, azilsartan will show that it is more effective compared to olmesartan in hemodialysis patients with uncontrolled hypertension. And if we switch patients who are already on olmesartan with suboptimal control of blood pressure, when we switch over to azilsartan, they could be safely, they could have their blood pressure reduced as measured by home blood pressure monitoring in hemodialysis patients. There is a lot of evidence to show anti-inflammatory effect, which is very conducive in metabolic hypertensives with coronary artery disease. And this was studied in the DIAMOND study, and hypertensive patients who had coronary artery disease were enrolled and assigned to change over from their past ARBs in the form of to either azilsartan or olmesartan, and followed for 3 months. The blood pressure predictably was better controlled with azilsartan, both systolic and diastolic, at the end of 3 months. And inflammatory markers in the form of high sensitive CRP, adiponectin, and pentraxin 3 were lower. And the trialists concluded that azilsartan reduces the blood pressure much more superiorly compared to other ARBs, and it has an equivalent safety as far as hypertensive patients with coronary artery disease is concerned. There are a lot of mechanisms for this pleiotropic effect of ARB. It could be a class phenomenon, but we know that there is an increase in PPAR gamma, favorably affecting the glucose metabolism and insulin sensitivity, a decrease in macrophage infiltration, increase in nitric oxide synthase function leading to anti-inflammatory and antioxidative effect, decrease in plasminogen activator inhibitor, so anti-proliferative and anti-fibrotic effect, decrease in glomerular injury, decrease in proteinuria causing renal and cardioprotection, and tight binding and slow dissociation from the receptor leads to superior and sustained blood pressure lowering, and well tolerated, effective, and safe in combination. So azilsartan significantly superior to valsartan 320 mg and olmesartan 40 mg in reducing 24-hour mean ambulatory clinic systolic blood pressure, sustained blood pressure reduction over 24 hours, and it is well tolerated. And the most common adverse effect for this drug, which has been seen, is GI upset in the form of diarrhea, seen in about 2% of patients. So key features are superior ability to control for 24 hours the systolic blood pressure, greater AT1 receptor blockade activity than other conventional ARBs, pleiotropic cardioprotective effects, which is probably a class effect, but there is good evidence now on cardiovascular metabolic markers. Pharmacokinetic profile enables us to administer it once a day, more effective in reducing 24-hour mean systolic blood pressure, generally well tolerated, diarrhea being a common, the most common side effect in 2% of patients. Some patients do report headache and dizziness, but if you measure the blood pressure, it's not too low. No orthostatic hypotension, very low rates of treatment discontinuation due to adverse events. There is no dosage adjustment required as far as or severe is concerned, hepatic impairment. So the key takeaway messages: there are new therapeutic options which we are constantly searching for better control of blood pressure in resistant hypertensives is now available. Blocking the renin-angiotensin system pathway continues to remain as an attractive therapeutic target, and newer innovative drugs are now coming up. Renin-angiotensin system inhibition is a well-established principle of nephron protection as far as diabetic nephropathy is concerned. Not all ARBs have a sustained antihypertensive effect. Selective blockade of AT1 receptor, that too for a long time, is perhaps desirable. Greater reduction in blood pressure than in control in patients with hypertension is a very important thing as far as new molecule azilsartan is concerned. It perhaps is the optimal ARB choice as far as patients with hypertension and renal impairment is concerned. Evidence to suggest that azilsartan reduces kidney disease, kidney damage. And even in those end-stage renal disease who require hemodialysis, no dose adjustment is required. There is good enough evidence that reduces serum creatinine levels and decreases the LV mass index. Thank you very much for being with me. questions. Dr. Srinivas from Mumbai has a question. Is it safe to consume or apply when pregnant? Unfortunately, there's no data, no ARB is studied in pregnancy. So if you go by past experience, it cannot be recommended as of now. Same, Dr. Aruna from Pune, Azilsartan, is it safe while breastfeeding? Unfortunately, we do not have evidence for the same in pregnant and lactating women. Has not been studied. Dr. Venkat from Mysore wants to know at what frequency do you need to use Azilsartan? It's a truly once a day ARB. It has got a long dissociation coefficient, so it gets very well attached to AT1 receptor with a slow dissociation, so you can use it once a day. A question from Bangalore: should I take Azilsartan empty stomach before? So food does not interfere with its absorption, so we can advise the patients as they are comfortable. Preferably after food is what we do. Is this medicine or product addictive or habit forming? Well, no. When we use antihypertensive drugs, we have to tell the patients that we are looking at a lifelong therapy. So it is a more a requirement, an absolute requirement, rather than being addictive or habit forming. The question from Delhi: is it safe to drive or operate heavy machinery when consuming? Absolutely no issues, because there's not going to be a tremendous fall in blood pressure for us to be worried about. And we know from sprint data that you can reduce the systolic to less than 120, and these patients do not develop giddiness. Can it be stopped immediately, or do I have to slowly wean off consumption? Well, we have to see, why do you want to stop? If you want to stop, you have to reduce the dose. So I would never stop an antihypertensive drug, because I'm looking at a powerful antihypertensive. And if I need to, for some reason, come off the drug, I would probably reduce the dose to half. If somebody is on 80 mg of Azilsartan, I'll probably scale down the dose to 40. If a patient is on a concomitant diuretic, I'll probably get rid of the diuretic. When should we not use Azilsartan? Well, as of now, not use is something which I don't think I can give an answer. I would probably be very, very comfortable to use it in moderate and severe hypertensives all the time. What is the maximal dose? Well, at the moment, all clinical data is with 80 milligram of Azilsartan. What other drug affect Azilsartan? Any contraindications? Well, no. But the only thing we are worried about ARB is a fall and decline in renal function, and we would probably, as a class, not use ARB, including Azilsartan, in those with bilateral renal artery stenosis. Those with unilateral renal artery stenosis, I would still not hesitate, just for like any other ARB. Okay, useful webinar. Thank you very much. How it acts as a reverse agonist? Well, it is the binding property to the AT1 receptor, so that's how it acts. It is the same mechanism as we see with olmesartan. It is not effective as telmisartan. Well, telmisartan is a weak antihypertensive. I would probably beg to disagree here. And if you see sprint data, the telmisartan would seldom ever bring the blood pressure to 120 or less, and sprint data very clearly shows the intensive arm where the blood pressure has been brought to systolic less than 120, and that was possible only with Azilsartan. So I would fail to, I would probably disagree as far as if efficacy is concerned, clearly more superior than telmisartan for sure. Do you feel still more number of trials should be done on Azilsartan? Well, sprint is a very good data. I mean, we would be happier, more the merrier, more data, we are more confident of using, but sprint is a good enough, very nicely structured trial, and I don't have any apprehensions in mind as far as usage of the drug is concerned. Its usage in heart failure patients, well, I would extrapolate the data from other ARBs at this point of time. Definitely, yes, there are more trials on heart failure in the pipeline with ARB Azilsartan. I'm sure in the years to come, we will have a very favorable answer to this question. My patients are not controlled with 40 milligram. Yes, please, you have to increase the dose, up titrate to 80. If not, we have to think of adding a diuretic for sure. Is there any hypotensive effect? Well, as I said earlier on, there's no hypotensive effect shifting from telmisartan to azilsartan. The reason we are shifting from telmi to azilsartan is an improper or ineffective blood pressure control. So you should not be worried in switching over to azilsartan. What are the creatinine levels? Can azilsartan be treated? Well, there is plenty of data that we can use azilsartan in any stage of renal disease, whether mild, moderate, or severe, including those who are on hemodialysis for some reason. If there are no more questions, thank you very much for being with me. I'll be happy to answer more. I'm around for some more time. Thank you. Yeah.
1 minute. Hello?
Useful.
Another.
Is it over?
No, 1 minute. It's over, na? Hello? Questions are all questions are over. No more questions. Okay, sir, we can.
Two more questions.
2 more questions.
2-3 questions have come. Can we use 40 milligram azilsartan twice a day instead of 81? It's a truly once a day sartan, so we should not use it twice a day. We should use it once a day. And the T half is something at 11 hours. So we are not going to give any benefit of using twice a day. We should use only once a day. Azilsartan works in nitriuresis in elderly patients. Sorry, I'm not able to follow this question. Patients are not getting 40 or 40, then we have to add a diuretic, or then we should consider adding a calcium channel blocker as well. I did not get superior result compared to telmisartan. Well, I'm not sure why it's so, but I'm sure if you titrate the drug properly from 40 to 80, the result is going to be dramatic. If blood pressure doesn't get controlled, what should be the other medicine added? I would prefer a diuretic. It could be a thiazide or a chlorthalidone. Still, the acceptance is slow. Do you see future in azilsartan? Yes, with time, yes. And if you go carefully and look at the trial data, azilsartan is very superior. I do expect intrarenal blood pressure to come down and reduce the proteinuria, and it should have a favorable effect as far as renal failure is concerned. Is there renal safety human data? Yes, I did share with the renal safety human data on azilsartan, like telmisartan. Yes, you have data, and the better blood pressure control, lesser intraglomerular hypertension, less proteinuria, and definite renal protection is going to be superior. So as far as acceptance is concerned, it is we as physicians, we have to go by whatever is scientific data available with us. The sprint data which got published in NEJM is very important for all of us to look up. and I'm sure that will encourage us to use azilsartan. Okay, thank you very much for being with me. If there are more questions, I'll be happy to sort it out. Thank you very much.